How do we treat? I think we have a shotgun approach for most of these nephrotic syndromes. Everybody has this Ponticelli protocol. They are both loaded with cytotoxic therapies, which has so many side effects. Sometimes there's a protocol you just follow. You don't know if you can stop in between, before, later. What's the duration? How long? I heard the CNIs are being used as the predominant agent. So how long do you treat? 1 year, 2 years, 3 years, or 6 months? The guidelines, we're not there yet, but eventually, hopefully, will be there someday. So just, I think, for the trainees and just to go to the basics and look at the filtration barrier, just to understand that. So this is the vascular pole, this is the tubular pole. You can see these open capillary loops, which has the membrane. This is the basement membrane. As you can all see, this is, and the endothelial side, epithelial side, this has night foot processes and slit diaphragms. And on the endothelial side, those are the fenestrae. So this is a very, I like this electron micrograph because you can see these tiny foot processes and then the stack and then the tubule start. So this is how kind of, it covers around it. So the capillary wall and the basement membrane is really surrounded by these foot processes and the stack. And this is the electron micrograph. Similar to this, you can see the basement membrane, you can see the foot processes and how there are these filtration slits, and things are in such an order that you don't see albuminuria in the normal conditions. So what happens in membranes? It's disease when you see subepithelial electron dense deposits. These are immune complex mediated deposits. So this is the early stage when you start to see these deposits. Then the membrane grows around these deposits. So the kind of having the picture of the spikes. The next stage is when the deposits become intramembranous. So there is so much growth of the basement membrane around those deposits that they become intramembranous, and eventually there's a washout time. And then this is the late stage membranous as well on the pathology. So board question, I'm sure everybody sees that. Anytime you see the word silver stain is equivalent to membranous. So David Jones, he described these spikes. The spikes is actually the basement membrane around these deposits, and they project from the outer surface of the basement membrane. When you do the immunofluorescence on IF, there is IgG4, predominant IgG4, very fine granular staining, and this is uniformly in the subepithelial distribution. So normal EM, and I think on the membranous you can see these deep deposits on the subepithelial side. So how have we historically classified or approached this condition? A big chunk, 2/3, 3/4, we always used to call it idiopathic, right? We don't know what caused it. We don't know, we did not know any links or any associations. And 20 to 30%, there was some other systemic condition, infection, cancer, solid tumors, or liquid tumors. So anytime we diagnose membranous on the biopsy, those patients, we mandatory do a secondary workup for any infection. So if they are in a certain age range, they need colonoscopies, they need the cancer screening. Infections, and there is association with membranous B and C HIV, very known association. Chinese think because they have too much pollution in their air, and that's the reason their membranous is on spike. And they have some herbal medicine and intervention therapies going on to curb that. So what has been the historic observation and difference between idiopathic, which we now call primary, versus secondary? So this is the IgG distribution. As you could see in the idiopathic form, this is predominant IgG4, whereas lupus, cancer, there is IgG staining, but it's less likely to have IgG4. In lupus, you see this full house effect. You see everybody, like all the other immunoglobulins, but you don't see that much IgG4, although you may see some. So And then sometimes you see either mesangial deposits or subendothelial deposits. So we did not know what caused this IgG4 deposition and if there was some association. So have we known about the pathophysiology of membranous? Yes, back in 1950s. Hayman nephritis model for membranous is a known entity. So you take the crude kidney extracts and create the immune response. And there was an antigen which was this megalin in the rat which was found, but we never knew what's the megalin equivalent in humans. So what is like human antigen? We did not discover it in the past. So anytime, once this immune response is triggered, there are antibodies against megalin which then lead to damage of the membrane by the common pathway using the complement fixing membrane attack complex C5b to 9, and it causes damage at the membrane and leads to proteinuria. So but the human membranous, what caused it was remained unknown. So there were, some of the theories as what could be the cause. Okay, so I'm sure you guys you have seen this slide before. So there are three models or three possible mechanisms. Either there are circulating immune complexes, antibody antigen complexes, उधर सीरम में भाग दौड़े हैं, वो दौड़े लगा रहे हैं और एकदम से किडनी ने उनको फिल्टर कर दिया, and then created the response, like you see in serum sickness. Or there are some in situ immune complex involving the native podocyte antigens. So there is an antigen in the basement membrane somewhere which is native to the membrane, and you start the antigen antibody or immune complex response there. And the third model was, what if there is an antigen that gets filtered through, gets planted, and now there is antibody response against it. So it was not until early 2000 and in 2009 when Dr. Becky published this observation in his paper about the M-type phospholipase A2 receptor, PLA2R, as the target antigen. So the human equivalent of the megalin in the rat model was finally discovered. So there is an discovery of the antigen and the antibody in that case. So in his paper he took patients with membranous, 5 patients, and they all, these patients have a specific reaction to this 185 kilodalton glycoprotein in a non-reduced glomerular extract. So one of the observation was that maybe it's how we were doing the experiment. Maybe in the rats, the antigen and the antibody was available because those were, this reduction state had nothing to do with it. But in humans, this was only visible in the non-reduced state, not in the other kind of state. So this was the PLA2R antigen. And then in his case study, the 70% of patients with idiopathic membranous had this antigen and this subsequent antibody. So this was proposed that this is the major antigen in this disease condition. Whether this was absent in secondary form of membranous, absent in other diseases, and of course normal control. So when they did this co-localization experiments on the electron microscope, you will see that the IgG4, which is the antibody present in membranous, it co-localizes with the same PLA2R antibody. So that was, so then we postulate, okay, this is the association, and this is how it looks like. So it's present in other organs as well. There is constant supply and recycling of this antigen. And what starts all this is still not very well known. And how is this complement mediated activity? Like what leads to the pathogenic mechanism? Is this the complement mediated injury, and or if the antibody has some sort of agonist properties, just like in thyroid conditions, the antibody is actually causing some of the damage itself. Then, because there was some cluster of cases, and the case banks were So they were doing other testing as well. So there was another antigen which was discovered, is THSD7A, and this was in 2014. Again, the size is 250 kilodalton as opposed to 185 on the PLA2R. Its size is different, but it shares some of the features, like the glycosylation is the same, the location where it's on the membrane is the same, and also, the reactivity was found in the non-reduced state. And I think that was one of the reasons why these antigen and antibodies were not discovered before. So this was, taken from the same experiment, again, predominant IgG4 subclass. If you try to create the reaction in the reduced state, there was no activity on the Western blot, whereas in the non-reduced state there was. And interestingly, when this is one patient example, so if you see the timeline, this patient was treated in 2012, February to January 14. So the patient was treated with CNI and the prednisone. So the antibody activity peaked at a certain time, and when treatment was started, the antibody level faded away and the proteinuria actually declined as well. So there was some more direct association. Genetic studies has been done, and then HLA-DQA1 is found to be by looking at several cohorts of few hundreds of patients. So there is a risk allele found, which is HLA-DQA1. So we talked about some planted antigen as well. So on this side of the picture, you could see the antigen which is free floating somewhere in the serum. Now got filtered through, got stuck somewhere in the membrane, and then the antibody-antigen reaction started. So this was the observation in the pediatric population. So milk and membranes. So there is a serum albumin which got through the intestinal barrier in the kids. So the kids' intestinal barrier is not very mature. So it led to absorption of this albumin, and it led to antibody-antigen. So this was the antigen which got filtered, got planted, and there was antibody response to it. So this was considered as one of the causes. Again, rare, only seen in the pediatrics. And it is said that beyond the age, 1 year, so once the infants, they cross age 1, you don't see it very commonly. So again, I think similar observations that I think in this slide, they said the BSA, the bovine serum albumin and antibody, so when they saw that the PLA2R was not there, so this was identified as a separate entity. So how can we utilize all this boring pictures and this scientific baseline, basic science? How do we convert it from the bench to the bedside? So this has helped us to go to the next level. Now we can change the classification. So then there are several case studies, and several people have these registries, and in all of these you can see that PLA2R positive cases are somewhere between 50s to 80%, so roughly 65%. There were some other, in some of the studies, the PLA2R was also detected in secondary membranous. So just to add some of the noise in the background, although because 70% of the idiopathic patients have this antibody, but some of the secondary patients, very rare though. In this study, like lupus patients, 20 patients, so some of them had PLA2R antibody, likewise hepatitis B as well. So we don't know which, why it was found in these patients when they already had the secondary condition to explain their membranous. So there are certain areas which are still not very well known. But I think now we can have the ability to check the PLA2R antibody, and also you can check the PLA2R staining for the antigen on the biopsy specimen. Have you ever ordered this antibody? Do we have this available? Not yet. Dr. Tariq, I think you have ordered these, right? So So it's I mean, I think I will consider this as a luxury, because if you have the antibody or some sort of classification system, you can do you can avoid doing a kidney biopsy at some point. So patients, so now they either can have the antibody present in the serum, and also the antigen is present on the biopsy specimen. So that's the 70% of the lot. And this is PLA2R mediated active primary nephropathy. You can still have negative antibody, like maybe at early stages, and positive antigen, and vice versa have been seen as well. So that was 15%. So this is PLA2R mediated primary membranous, but maybe at the time you are doing the testing, this is inactive, and you may not need to treat them with Monticelli protocols, or you can just get by just doing some monitoring. So, and then THS D7A. I have not ordered this. I don't think it is commercially available yet. But it is. So have you ordered it yourselves? No, I
okay,
I haven't.
It was, I think 6 months ago, and Eliza kit was launched.
So did your patient has positive or not?
I think if you are PLR2 and you are suspecting cancer, because this is the antibody which aligns with a lot of background noise with malignancy associated.
Exactly.
That avoids you doing whole body screening for cancer.
Yes, this was the observation. This antibody has more association, more than 20% of the patients who have this antibody, they were diagnosed to have some sort of a cancer within the 3 months period. So this antibody, if it is positive, this may actually save your patient, because now there is strong association with cancer. You can do some workup. If you can find an early colon cancer, early lung cancer, early stages, you can treat it and cure it. So it encompasses maybe 3 to 5%, but there are still some antibodies we don't know. But we have, I think, so far covered some association up to 80 to 90% of these cases. So this is how the new classification or the new system should look like. The primary, no longer idiopathic. Now it's called primary membranous. 70 to 80% or maybe 85% are PLA2R associated, another 10% THS-D7A associated. There are some antigens which are not known. We discussed about the milk and membranous and early childhood membranous nephropathy. On the secondary, there are some conditions like SLE, hepatitis B, which has these conditions are also autoimmune, but we do not know exactly what antibody is involved in this condition. But cancer, high association with THS-D7A, but not necessarily a cause and effect relationship. We still don't know what happens in the de novo membranous and what happens in the membranous after allogeneic stem cell transplantation. So what about transplant? So what's the difference between the recurrent GN and de novo GN? So recurrent is if somebody had FSGS, it comes back in the transplant. If you have one GN, if it comes back in the transplant, that's your recurrent. But de novo, somebody started with diabetic nephropathy or hypertensive nephrosclerosis, now they have a GN, which is biopsy proven. So membranous is actually the most common cause of de novo GN. It's 2% of all renal transplant. Late stage, it has some association with the chronic AMR as well, although because the lesions look similar, the waters get muddy in that period of time. So again, in transplant, they have IgG1 deposits predominantly, not IgG4, and it's negative for PLA2R. So there must be a different or separate mechanisms. In recurrent, somebody who had the membranous before, if the antibody was positive, they are more likely to have recurrent. And it is advisable to sometimes delay the transplant until the PLA2R is negative. And then again, the mean time for really bad recurrence is 13 to 15 months, although you can start to see some deposits very early on because the antibody is present in the serum. And again, the recurrence rate is high if the antibody is positive at the time of transplant. So treatment options and how do you monitor the response? So the complete remission is really kill that proteinuria, less than 0.3. Partial is if you bring it below 50% reduction and below 3.5. No remission, less than 50% reduction, relapse when you have more proteinuria and ESRD, you all know. So the treatment options have been used are the cytotoxic drugs and steroids, the ponticelli protocol, Dutch protocol. This can go on like heavy shotgun approach, immunosuppression for 6 months to a year or even sometimes longer, the steroid arm. CNI with or without steroids have been used. So do you always add steroids when you treat membranous? Do you add steroids all the time? Have you treated somebody without steroids, only CNI as well? Rarely. People have done that, it just takes very longer time. And again, we all weigh the risks and benefits of the toxicity. So B-cell depletion, rituximab, I have had good success with some resistant cases in either idiopathic not. So I had a patient I inherited that patient. मैंने कहा वो मुझे जहेज में मिल गया एक nephrologist वो female से पहले who left the practice. So we tried every CNI, both cyclosporin and tacrolimus. Patient kind of bounced back and forth. Somebody gave him Selcept as well, and Selcept, there is no data to support the use of Selcept. All the Selcept data in membranous is inferior unless patients have lupus. So lupus is a separate category. So we gave that young man, I gave him 1 round of rituximab, and I think a month later, his proteinuria was from 10 grams to undetectable. So I have had actually good success with the resistant cases to use rituximab. And ACTH, the new drugs, have been tried. So small studies show some promise, large studies are yet to be done. But how can we use the antibody itself to monitor the disease activity and response to treatment? So some of the studies is when patients are nephrotic, the antibody levels are high. When they achieve remission, the levels go low, and when they have relapse, the levels go high again. So there is, you can see, there is some association. So what if you can monitor the antibody itself and predict what will happen 3 months later? Because even when you treat, it takes 3 to 4 months for antibody levels to come down, another 6 months for them to go away, and then, but proteinuria persists. And there is direct correlation between antibody levels and proteinuria. So this is just to prove the association. And again, if patients who have antibody present and then they either achieve remission or they don't achieve remission, I think there is something to do when once the antibody level is gone, they're more likely to be in remission. And also remission-free survival, so chances of relapse. So if patients at the time of termination of treatment were antibody negative, they had longer survival in remission. So their relapse was delayed. So somebody you treated, you got their antibody level down, they remained in remission maybe 5 or 6 years longer. I'm just giving you an example. Then when you stop the immunosuppression, the levels were still there, so they were more likely to relapse. Another observation, which is this immunological remission, is actually this comes first, followed by the biological remission, which the marker is proteinuria. So you see in this case, this study, the antibody levels after the treatment with rituximab went down, months following the initial treatment, whereas the proteinuria lagged behind. So the patients may have negative antibody. They may continue to have proteinuria just because it takes time for the body to recover from this injury. And this leads to, it's the same expression in a different way, that as you could see, there's clinical disease, immunological disease. You start treatment here, patients have both antibody and proteinuria. Antibody levels go down first, followed by the proteinuria. So some of the correlates, again, it's 80% sensitive, but considered to be 100% specific, although there are some caveats you can see in the Hep B and some other population, but I can say maybe 99% specific. It comes several months before proteinuria even starts. So it's really up to you when and where you catch that patient in the disease process. If the levels are going down, this will predict the remission. Patients, when they have either high level or levels are not coming down, they either need longer treatment and or a different treatment. Antibodies are positive in nephrotic state, and again, they decline prior to decrease in proteinuria, go away in remission, and it comes back with a relapse. So this is now considered a good marker to monitor the disease activities. But there are several questions which are still unanswered. What's the best way to measure the antibody level? I think there is some conflict about what level, what's the cutoff. I think there is some controversy going on there. And again, is it a level below which immunosuppression does not have any role? You check the antibody, the level is so low. You can monitor lupus by doing complements, doing antibody levels, some other disease condition too, anti-GBM is an example. So, but do we have a cutoff below which really you don't need to expose patients to immunosuppression at all? You just do supportive care, move the clock forward, bring the patient back, and see what happens. Role of biopsy. So right now the recommendation is still to do the biopsy, but at some point I think we will come to a point when really if you have any, you just send a nephrogram, an antibody panel. If this comes back positive, then you treat this patient in this particular way, and there is no need to do kidney biopsy, no need to do a repeat biopsy. I just saw a patient for second opinion for second time. I think I shared my story with our class the other day. Back in 2014, the gentleman was high 60s, now he is in his early 70s. Classic nephrotic syndrome, biopsy proven, membranous, PLA2R positive both in the serum and on the biopsy specimen. They couldn't run the analysis, but patient had antibody positive, was treated, had a relapse 2 years later. Was treated again with the cyclophosphamide, the Ponticelli protocol. Now, he's been exposed to lots of cytoxin already. He's on anticoagulation. So his creatinine highest was 2.7, 2.6. Every time he's in remission, it comes down to 1.6, 1.4. So 6 months ago, creatinine was 1.4, proteinuria was less than 500 milligrams. But then the antibody levels started to rise. So the nephrologists continue to monitor antibody every 3 months. Now patient is on anticoagulation and does not want to, he's kind of looking at his options. Should he treat, is this end state? Because now his creatinine is again 2.8. So I think we decided to treat him with rituximab just based on the rise of the antibody and rise of proteinuria and rise of creatinine, and we are yet to see what happens. But now we have avoided exposure to another cytotoxic regimen. And then again, the other flip of the question is, what is the role of immunosuppression when patient has secondary membranous but also have elevated antibody levels? So patient with maybe a cancer or systemic condition also have PLA2R positive. So we don't know we just we continue to do what we are doing with those patients. And I think this is a good segue to develop more targeted, more biological therapies, so which has less toxic potential. Now I looked at clinicaltrials.gov web page, and when I searched membranous, there were more than 200 searches. So there, in many parts of the world, people are either doing interventional studies or just the observation, and then some folks are using, in China, herbal therapies, and some labs are using really monoclonal antibodies. So there are, drug development on the rampage to see if we can have more targeted therapies. So this is my last slide. Again, I think recently, so this algorithm is, and I would call it suggested algorithm on the basis of this. If you have a patient, how do you evaluate them? You do the basic tests, you check their complements, the common nephrogram, the panels, and then if PLA2R is part of the antibody panel as well. Do a renal biopsy to confirm membranous. I hope that at some point we don't have to do renal biopsy if we have a very positive, response to the antibody to begin with. If they are antibody negative on this side, then check if the biopsy staining is positive or negative. If it is negative, look for secondary. Do either supportive care or treat the underlying cause. So if there is cancer, do the workup and treat the underlying cause. If they have antibody negative but the biopsy staining is positive, so maybe they still have the inactive membranous, so monitor them periodically. But if the antibody is positive, they have active PMN, proteinuria more than 3.5 grams, then start them on immunosuppression of your choice. Monitor the antibody. How often this should be done? In one paper, they suggested monthly, which is extremely expensive and I think probably not doable. Other people, they talk about maybe every 3 months. And reassess it at 6 months to see if the antibody is not coming down, just change the therapy and then continue to monitor. So you now have a biomarker. And then if once the antibody is negative, maybe at 3 months interval, you started them on Ponticelli protocol at 3 or 4 months, the antibody is gone, proteinuria is reducing. You really don't need to continue the regimen beyond a certain time. You really don't need to expose them to maybe CNI for 3 or 4 years. You can stop at year number 1, year number 1.5. And in between cases, you have the ability, based on the antibody level, to do some sort of a monitoring. And if the antibody starts to go up, you can always restart the treatment. Thank you. So happy to take any questions. I hope I completed within 30 minutes or so. Please.
We were talking about the rituximab and the response in CLAR-positive patients. What about CLAR-positive and CLAR-negative? How is the rituximab performing in CLAR-negative?
So it all depends. So in PLA2 or negative, so what's the then diagnosis? Is this lupus, or does this patient have like a secondary form of membranous in the setting of cancer or autoimmune disease? You really need to treat the underlying cause in that condition.
Like say we are unable to find that. We're talking about the local scenario. We are not in availability with CLAR in the serum. So the usual challenge is we need to diagnose without. In that, what do you suggest? And luckily, just yesterday, for the first time in Pakistan, I have seen a histology report with a CLAR-positive in the histology. But with that, there was C1q positive, and the patient was ANA and ASDNA negative, and C3 and IgG were positive. C1q were positive. Is there any relationship of that C1q? Does it tell you anything?
Yes, I think C1q was, I think in all some of the studies I looked at, C1q is usually negative in the primary membranous patients.
That's true, but if there is a situation, now this is a real-time scenario that I have faced that I have mentioned.
So you have a patient with membranous, you are unsure of the antibody level, this patient has, then you use the proteinuria as your biomarker, and then you just treat them with either the first-line agents or second-line agents depending upon your local expertise and your choice of therapy, looking at the patient's risks and benefits for toxicity. So you still have to treat them. Do they go into high risk, intermediate, or low risk category? What's the degree of proteinuria? Sorry,
in the middle category.
Middle category. So, but antigen is called, and then so it's 3.5 grams. So I think according to this proposed regimen, maybe you can start treatment early instead of waiting like another 4 months or 6 months.
And very last question. We were talking about the cells and microphenolate mofetil as a treatment. What about if the patient is having a C1q positivity without any artificial screen other than that being positive and still CLAR positive? Is there any study or any case report that is suggesting that microphenolate mofetil might be useful in that?
So maybe let me ask that, like, if you want to answer this, because what all the data on CellCept in this primary membranous is not as strong. I mean, people have used CellCept. I'm not saying they have not, but the data is inferior to other therapies.
Maybe I can help. I agree with Umar. I think that's how I would approach it, focusing more on clinical, more on proteinuria. I think the C1q and C3 staining you mentioned, you got to be really careful. C3 is a very sticky molecule, and you often see those on renal biopsies. C1q nephropathy exists, so you got to worry about that if you're thinking about that, but the signal has to be 3+ or more. C1q is telling you classical pathway of complement system is involved, right? C3, on the other hand, is telling you alternative pathways involved. So you got to be careful because you can't have both coming together.
But the real-time scenario will work. There are usual cases, or in that scenario, we are not sure what to do. For the primary disease mortality, what lost all that. We're confused.
Yeah, I understand. And then I would also question the validity of where the biopsy is done and who's reading it, and what's the local expertise of reading complement signature on the renal biopsy.
Dr. Murthy, you want to say something? Because I have an observation. I think one of my colleagues who practices 6 months here, 6 months with us, and she tells us that C1q nephropathy is on rampage in Pakistan for some reason. We don't see C1q nephropathy too much in any of the biopsy conference or pathology conference which we attend. And she always questions the pathologist, like, where is C1q? And we were like, oh, we don't see it very commonly. But I don't know, for some reason, so the question is that valid? Maybe you want to comment.
So one thing which means, I'll just take this. Remember, this is IgG4 antibody we are talking about, CLA-R2, which is a bit of a paradox. That if it was an immune complex disease, one would expect IgG1. IgG4 does not normally bind to complement. So that is the paradox for this membranous nephropathy. And that's why what Umar was saying, that is possibly antibody goes and binds to an antigen already present in podocyte. That makes more sense than complement pathway. So complement pathway is less relevant in membranous nephropathy because the type of antibody we are talking about, which is IgG4. CLA-R2 antibody staining for the kidney biopsy, even we struggle in the West. It is very promiscuous staining pattern. If you are doing immunofluorescence, you have better chance. If you are doing immunoperoxidase, which possibly most of the labs in Pakistan will be doing, then forget about the specificity of that staining. As far as C1q is concerned, I don't know what it is used. Is it immunofluorescence they use it, or they use immunoperoxidase? But, so it's C1q nephropathy. If it does exist, it doesn't show phenotype of membranous. That's the one thing. We use C1q antibody, my histopathologist uses it to see this lumps and bumps pattern, which we see in silver staining. When you can't see IgG, he will just look at C1q is co-present with IgG usually, because it's a very sticky antibody, it's a complement. If you say that your double-stranded DNA is negative, right, you still can have lupus with seronegativity when you've got ENA positive. If you do the whole ENA pattern, you can still capture out the seronegative, which are 10 to 15% of those patients can have lupus. And I tend to agree that whether there is a C1q nephropathy as an entity, that's a label, because we don't know how to describe that. There are instances, one of my colleagues, John Fihali, who used to be the president of ISM, he swears by it that there is a C1q nephropathy in his experience. And I would trust him because he's the Mr. IgA guy. And Mr. IgA guy tells you that it's quite usually confusing with IgA on morphological pattern. So if he can't find IgA in the biopsy, he will restain it. He will do EM to see if there is mesangial deposit. If he can't find it, then he will say it is C1q nephropathy. C1q nephropathy, there is no specific treatment. If it is outside the lupus context, there is no treatment. If it is within the lupus context, but what it sounds like in your case, I'll be very honest with you, then it should be treated like lupus. And in that scenario, prednisone and MMF should work. So if you want to do a therapeutic trial for 3 months, which is the less toxic, you do pred and MMF like you would treat any membranous or any other lupus nephropathy. Forget about PLR2 staining. Whoever has done this, I think it's not possible that he would be able to detect it. In a country where you can't have a serology test available, but you have got an it begs the question. So I would calm you down. The other thing is that I used to practice law of 6 in membranous nephropathy, which has clearly changed after the antibody discovery. Law of 6 is that you, for 6 months, observe a patient to see if he goes into spontaneous remission. except if the proteinuria is greater than 6 grams a day, you should start treating it early, because that person will not go into remission. So law of 6, observe for 6 months. If the proteinuria is less than 6 grams, monitor it. If it goes above 6 grams, then treat it. Otherwise, don't treat it for 6 months. Nothing will happen. Or during your observation period, you see a rise of 60 millimole. I don't know how that would be. Possibly it would be 1. I don't know what would be the creatinine equivalent to 60 millimole. I don't know. 0.8. So if it rises by 0.8, I would regard that as significant renal decline. If you were to roll out dehydration of patients' hypovolemic state, then you start treating it. Now with antibody titers, which Umar said that we don't know what is the normal level of this antibody, I have found in a series of sarcoidosis many patients with no proteinuria. Because when we found in my rat model that this, it is not present, ironically, CLAR2 is not present in the podocyte of the rat. So we don't have a reliable preclinical model for this antibody. But ironically, this is present in the lung of the rat, which is unbelievable. And we just thought that if it is present in the lung and sarcoidosis being a lung condition, would that be the model? So we were doing TB and sarcoidosis. This is another interest of mine. And we found at least 20% of the patients had not very significant, but positivity for CLAR2. And when you look at the tissue of the lymph node, which we took the biopsies of, there was definite upregulation of CLAR2 in that, and it was staged for that antibody. So this can do something in extrarenal tissue. You can get borderline positivity. But what is it? But there is a recent study which says that if you have got proteinuria of greater than 8 grams and CLAR2 antibody titers of greater than 37, almost certainly that person will never go into spontaneous remission. You need to treat it. So this antibody is at least given another angle rather than those clinical biomarkers, which I still think are very useful. What I told you, law of 60, 6 months, that is perfectly okay because you don't have CLAR2 positive. But if you have got proteinuria of greater than 8 grams and if you have got CLAR2 antibody positive greater than 37, general feel is that those patients should be treated straight away rather than waiting for 6 weeks. So you should treat your patient for lupus with present MMN.
So maybe, maybe in the interest of time, I've been asked by the Dr. Ahad Tayyum that Dr. Umar, just close your shop, go back, sit there, and let somebody else to talk. So maybe I think we can go to the next speaker. We can talk offline. And if anybody else has questions, I'll be happy to talk. Thank you. I apologize, but I think in the interest of time we need to move on because people do have some appointments at 4 p.m. so we need to finish the program by then. So just a few announcements. One is that I am, apart from the foreign faculty that has sort of accepted our invitation to talk here, I'm very, very happy and humbled to sort of announce that a few of our foreign delegates who also who were able to at least land before the airspace closed over Lahore are still attending and they are in audience. I'm thankful to Dr. Tariq Nawaz who have from Penn State and Dr. Khalil. Apart from them, if anybody else is here, I'm very thankful that you made the time. I think the thirst for knowledge, if this remains the same, I don't think we've got anything to worry, and inshallah all will be well. Second thing is that I would like to report that we are live on YouTube. All you need to do is punch in Pakistan Society of Nephrology, and there's a channel, dedicated channel, and that we are going live through that. So if there are any questions, they can be sort of in the bar below it. You can give the questions there, and we can discuss this over lunch. Lastly, just a brief history of this particular meeting. This meeting was started in Lahore at least by Professor Tahir Shafi and Professor Azazman, who is in attendance as well. And we do this every 2 to 3 months where consultants from all over Punjab bring their difficult cases, and we have an expert opinion session as well. This time around, this has been an exception because we have 3 expert opinions and only 1 case.
And just to give you a sense of how the case is presented for our foreign faculty, we're just going to do one case, and that is from Fatma Memorial Hospital. So can I invite Dr. Obaid to please come and present that case, please?
I'm a resident in Nephrology department of Fatma Memorial Hospital. So I would like to present the case of nephrotic syndrome. Our patient was 60 years old male with a history of hypertension, and he was on calcium channel blockers, indapamide and itovardi. So he had a history of thyroid cancer, for which he received treatment, and he presented a year ago with chronic hyponatremia for almost 3 to 4 years. And clinically, at that time, he was overweight and he was euvolemic. So we thought that the cause of hypernatremia is the use of indapamide. So we stopped at that time. And 1 year ago, his serum creatinine was 1.4 milligram per year. And the urine saline was down. So he also underwent injection with thyroid stimulation test to detect any remnant thyroid tissue in November 2018. And in the late December, we noted progressive development of swelling and uncontrolled hypertension. And he took diuretics for the swelling, and antihypertensives were also adjusted at that time. And he also took few doses of NSAIDs for pain. So creatinine increased, and potassium was also high, so itovardi was stopped because of these two reasons. And in the January, his edema progressed to almost NSR within 1 week. So his physical examination was consistent with the fluid overload, and the systolic blood pressures were high, around 150. So he was admitted, and all workup was done. The autoimmune workup was negative, and serum protein electrophoresis was also negative. Viral serology, HIV were also negative. So he was managed with the diuretics and salt restriction. He was pulsed with solomedrol because he was having high grade protein urea and worsening of creatinine. So he was pulsed with solomedrol, and later he was shifted to oral delta-carten, 16 milligram per day. And kidney biopsy was performed on 31st January 2019. It was reported at FMH, and it came out to be the minimal change disease. And bloods were even viewed at Shakathanam and then in USA, and the results were consistent with the minimal change disease. Immunofluorescence was negative, and it was not performed any other place, and electron microscopy could not be done at USA. These are the few, it's a brief overview of his labs during the month of January and February. So basically in January he had proteinuria plus 4, and which later on quantified and came out to be in the nephrotic range. And then his creatinine was fluctuated around 2.2 to 2.4 mostly. And he was biopsied on 31st January, and his P2C was 3.5 on 6th February. And you can see that it didn't improve, but somewhere after a few days it also increased 2.7, and then it grew up to 6.5 on 21st February. And during that time he was on steroids, oral delta-carten. So once he was admitted for resistant edema on 17th February, and he was treated with diuretics and salt restriction, and blood pressures were also controlled with antihypertensives. So basically in this patient, our initial impression was that he might be having FSGS or MGM, but surprisingly it came out to be minimal change disease. Because he's having increased creatinine, he was having hypertension, so we didn't expect MCD. So I would like to share a few studies in which the rituximab was used for minimal change nephrotic syndrome in adulthood. So it was a study which which conducted in almost 5 years, from March 2006 to 2012. And in this study, 41 patients were included. Those 41 patients, they all received rituximab. So the median age was at the median age of onset was 6 years, and about 28 patients had this disease about 15 years when they were younger than 15 years, and 41 patients were divided into two groups. Group 1 included 20 patients, and the group 2 included 21 patients. All of those were steroid dependent, having steroid dependent nephrotic syndrome. And they were also on immunosuppressions, like 10 patients were having steroids at the baseline, and 36 patients were using CNIs, out of which 24 patients were CNI dependent, and 24 patients were on MMF, and 20 were on alkylating agents, and 5 were using azathioprine. When they were given rituximab, the median age was 26. Like it was roughly 17 years from the onset of their diseases, and serum creatinine was around 92 millimole per liter at that time. So this will help us to understand what happened. So out of 41 patients with minimal change nephrotic syndrome, 3 patients were given only rituximab. They were not using any immunosuppression. And the 38 patients were those who were using immunosuppression, one or more than one, along with the rituximab. So the total out of 41 patients, 25 developed complete clinical response, and 7 developed partial clinical response, and there were 9 patients who didn't develop any response. So out of the 25 who developed complete clinical response, amongst 25, 12 patients had no relapse, and the 13 patients had relapse, and they were treated with those 5 patients who also developed relapse from the partial clinical response patients. So out of these patients, 17 patients, 13 patients again developed complete clinical response, and the 4 patients who developed partial clinical response. So here you can see that those patients who were having no nephrotic syndrome at the baseline, so they developed a good survival of they didn't develop relapse, and they enjoyed more of remission, relapse-free period. And those who were having nephrotic syndrome at the baseline, in those patients, the incidence of relapse was more. So in this graph, we can see that those patients who were given rituximab in the doses of like 1 gram, they enjoyed more of the relapse-free survival, and those who were given rituximab in 375 milligrams per meter square, they had more incidence of relapse. So the rituximab led to a significant and sustained clinical response in most adult patients with the minimal change nephrotic syndrome, and the further studies will need to identify subsets of patients that may benefit from the rituximab at the first line. So this is another study which is showing, which was done in 2014 and published in 2014, and it was conducted from 2008 to 2011. And the research group of childhood onset refractory nephrotic syndrome. And this study also showed that those patients who were treated with rituximab, and in those patients, 50% of the patients, they have a relapse-free period at 260 days roughly. And those patients who were placebo group, in those patients, 50% of patients developed relapse even at 100 days. So we would like to discuss our experience with one of our patients, which was a case of minimal change disease, and in that patient we tried rituximab. So patient developed nephrotic syndrome at the age of 3, and he presented at the age of 16 years with relapses. So that patient was treated with steroids and tacrolimus, and the patient remained in remission for 1 year. Then after 1 year, patient again developed relapse, and the patient was again treated with steroids, but at that time there was no response to tacrolimus and MMF for about 1 year. So patient was also having cosmetic, steroid cosmetic effects, and patient refused for cyclophosphamide. So we decided to give her rituximab, 500 mg weekly for 4 weeks. And patient remained in remission for 2 years. Then after 2 years, she developed a mild relapse, and we gave booster dose of rituximab, 500 mg of 2 doses. And patient again remained remission. And now she is doing well. Like she was married 6 months ago, and she is in remission at the moment. So the current status of our patient is that we are using oral glucocorticoids for like last 4 weeks, and there is no significant response. And we also decreased the dose of steroids because the patient was having vaginal myopathy. And we also treated the patient with Biennial furosemide and metronidazole for diagnosis. But still, the patient is having significant edema, and patient is on steroids for swelling. And now the question in this patient is that should we continue with steroids? Should we add the CNIs, or should we go for injection of insulin?
Basically, the idea of presentation for this patient was that to have a view about how to deal with this patient right now. He is number one. He is a patient who has been through a lot of things before, like thyroid cancer, and he is very, very particular about his disease and medication and everything. We have done the biopsy, and it's minimal change disease. He got it, reviewed from one of the other hospitals, and then he sent it right away to USA. So it was read in Florida, and they said, okay, this is fine. This is all minimal change disease and no interstitial disease or anything. Initial our thought was that maybe because of the non-steroid that he has used, it's just a nephrotic syndrome, minimal change disease. But it went so rapidly, and it was such an anasarca, and he was in distress. We had to admit him like 2-3 times just for diuresis. And his creatinine had jumped up, which I think, maybe is most likely because of the edema or nephrosarca, one can say, is related to that. Because just before that, it was like 1.4 and 1 milligram of creatinine. Now the question was, should we just continue with these steroids for another 2-3 weeks? Or, just add a CNI and then, make it more of a, levels and everything, or just try the rituximab. I know there are some case reports there. We have our own experience with one of the patients. It was a wonderful experience with such patient. And please.
Well, I thought you did a great job in managing this patient. This was a tough scenario.
These are 2 patients. So this is our current patient, and this is the previous patient.
Yeah.
She's fine.
Okay. On the one where you did biopsy and you found minimal change disease, would you consider repeating the biopsy? Because, I know you sent it to the United States and you had the biopsy reread it. If the tissue is captured at a location where you don't have the real diagnosis, you could still miss it. So would you consider re-biopsying that patient?
Yes, it's a possibility. The one thing is, as I said, he's overweight, number one. And now with the edema and everything, it was kind of a difficult biopsy, but we were able to get enough glomeruli. I think there were like 10 or 12 glomeruli in there to suggest that it was an adequate percentage of glomeruli. But, you're absolutely right. We may miss, some of the part, maybe FSGS, which is deep down there. I don't think that we did reach up to the juxtamedullary area.
So I just have a quick question. Right. So was an echo done in this patient? And age of the patient?
Age is 64, sir. Yes. He's
So
about
echo-
64 years old. Yes, echo was done and it's fine.
It's normal.
It doesn't have any ischemic
So
heart.
my only concern with this presentation is that the clinical presentation does not match with the laboratory findings, such as the resistant edema in a patient who only has 3 grams of proteinuria. That usually doesn't happen.
It's like up to like 6 grams.
We only
3
saw, I
grams,
think, in the
6 grams,
PCR3.
Yeah, it was like 6, 5 and 3. It the
So it's like
4.7, 6.5 recently. And then we had diabetes. Yeah.
right. Yeah.
No, this is the patient.
Yeah. So, and I mean, the baseline creatinine is, you said 1.4?
1.4.
1.4.
That was about a year ago. And it's been stable without any proteinuria. It was a bland sediment.
So I think I would really I would agree with what Arif is saying. Perhaps we need to, I don't know, just minimal change. Doesn't sound like this is minimal change. Just doesn't smell like it. And,
Sure.
we may be
Yeah,
wrong.
no, you're absolutely
Yeah,
right.
yeah.
We were also confused that, we're thinking maybe there's some FSGS.
Right.
So the histopathologist did say that it may be an early membranous or an early, FSGS.
So how about amyloidosis? Was the SPF effect was also?
SPF was negative, but amyloid, since, amyloid was not done since there was not enough evidence that there was any, deposits could be seen.
I think going through the case, listening to the story, just does not, the 2 and 2 don't just match. So the diagnosis has to be reconsidered. Whereas on the treatment option, you chose to go on one route, which is, stay-like route. You just need to give it some time before you change direction. Maybe you want to give it 1 more month or 3-4 months. I think that's the big question. And is patient now losing kidney function? Is creatinine rising? And the nephrotic syndrome is very resistant. I think the diagnosis needs to be reconsidered.
I think first I would like to clarify about the degree of proteinuria. In a patient with NSARCA, you never go for PCR, because the urinary creatinine will be all over the place. And I would trust your per 100 millimeter protein excretion, and I would just give a vague number of 1.5 liter urine output and convert that into the degree of proteinuria. Because when you're looking at urinary protein, look at the amount of variability in your spot creatinine. It's all over the place. That is the one thing. It's for the trainees that when they look at PCR and multiply it by whatever number and they say this is 3 grams or whatever, please look at the urine creatinine. If it is 1, it will be 100 PCR. So you've got to, first of all, focus on both parameters. Don't just look at the ratio in a person who is malnourished.
So to make it more clear, so if this is like 98.1, so you will extrapolate it into?
Sorry, as I said, forget about the creatinine. I would not. In a
So
phase
the
that
373 milligrams.
I would just say that if it is 306, which is per 100 milliliter of urine, you convert that into 1.5 liter urine, which you would expect a person should have. That would be your true genuine proteinuria in the scenario which you are presenting. So that's one point I would like to make. Second thing is that, yes, you send the biopsy specimen to America, and they also agreed with you with minimal change disease, but they didn't do EM.
Yes.
There is one place where EM could be useful, would be there to differentiate between early membranous versus minimal change. Even immuno will be negative on early membranous. You need EM, but Americans did not possibly have the sample or specimen or the slide to look at EM. So you can't rule membranous out by just looking at the biopsy. And I agree with my colleagues that this could be the case. But you don't want to do the biopsy, and if I was the patient, I wouldn't like to have a biopsy if I was fat and edema. And the question for me is that is there any other very simple way we can figure it out? That is it genuinely minimal? Is it FSGS or membranous? And the simple test is selectivity. Protein selectivity, when I was a registrar, we used to do it routinely in patients who could not be biopsied for whatever reason. If it is highly selective protein, which is basically the ratio of transferrin in your urine and IgG, if you are highly selective, it is only minimal. It cannot be any other pathology. So that way you could avoid your biopsy and give some more circumstantial evidence towards your minimal change disease by just looking at this simple parameter. And you can check. I wouldn't do the biopsy in this patient. Because even if it doesn't respond to steroid, you can always treat it with other things, assuming that it is, whether it is FSGS or membranous, you will give it therapeutic trial. And the patient you have got, very clued on. He knows what he's doing. He has gone through all the treatment. And it seems like that he's determining what treatment he would like from you. So he's very, very, it's like reads whatever the literature there is. So that sort of a patient, you have to also then evolve your practice to keep his confidence in you and say that, look, this is another test we have done, is minimal change. And I agree with the, Umar, that minimal change responds within 6 weeks in pediatrics. In adult, you have to continue for 3 months before you say it's a failure of steroid therapy. So you cannot say that you have given him a 6 month, 3 months of therapy. If you check out at 2 months and say it's steroid refractory, that is not according to the book definition of refractory steroid minimal change. So you have to try it for 3 months. But you have got a problem. Your problem is that the patient is already developing side effects. And that is proximal myopathy. I don't know how genuine, but possibly that is correct. So you can't take that. One thing which is disturbing me, that when you went through an elaborate presentation, one of your very nice work, by the way, whoever presented, really, Dr. Ubed, well done. If you were my house officer, I would have been very proud of you in UK. Well done. He said that you look for residual thyroid tissue. You did not give us the result of that, because he had thyroid cancer and possibly he had radical thyroidectomy. He didn't tell us because he had a result. You said that you have done it. So we don't know whether there is any residual thyroid tissue.
Negative.
And that was negative. And he is on thyroid thyroid, I hope.
Yes.
Right. So that is another thing. But still, residual thyroid tissue does not mean that a non-functional cancerous thyroid tissue is not present somewhere else. I don't know which sort of a test and how much reliable your diagnostic. And that is one thing which I'm slightly disturbed, that the diagnostics, the clinical skills of you guys is so amazing. Possibly you can make a diagnosis by just seeing the patient walk in your room. But I'm sorry to say that having seen what I've seen, that thing has not evolved into your diagnostic services. You see fantastic CT scanner. I was just driving and seeing fantastic multi-site CTs and the open MRI facility available. I read one on the board. It's okay, you can put a bloody machine. Is there anyone to interpret that thing? That's what I'm slightly worried about. That yes, you are think more trusting of your diagnostic service. But we even invest when we see a picture which doesn't tally with the underlying whatever pathology. We suspect our own diagnostics. We just go, we see the images and everything. So that's like worry I have. But the most important thing, which is again for the trainees, that if you are suspecting ever that there could be a malignant associated or infection associated GN, always remember for the trainees, and you don't know whether it's membranous or whatever the underlying pathology, cholesterol will tell you.
Just a question for the professors. Does the history of malignancy raise any bells that this could be membranous? And is there a correlation between prior malignancies and later on membranous diagnosis?
No. If it is cured, it should not be related. If you get a FLA-R2 negative or say thrombospondin positive in whatever scenario, it means that there is a mitotic figure, which is mitotic, whatever small microdeposit, which is now becoming more. Okay. If there is no malignant tissue, even dormant tissue should not give you malignancy associated. And that's why if you treat the condition, it goes away.
Okay.
Thank you. If you have got a malignancy, you treat it, you don't need the treatment for nephrotic syndrome, it goes away. But what I'm just trying to say is that it would be nice to look at the cholesterol. I don't think so it's tumor, I believe with you, it is not a relapse or whatever because of his oral condition. If the cholesterol does not go with this severe nephrotic syndrome which you're describing, it got to be a mitotic figure. Of course, tumor necrosis factor which will be produced by that tumor would keep the cholesterol level within normal limit. And the way he's become anasarca, etc., is slightly making me puzzling. That no matter what your test suggests, that he needs a very good PET CT, then I will believe, read by an appropriate person, that there is no microdeposits. And remember, a person who gets a thyroid cancer treated, they do develop other cancers as well. So we never forget that if he had a radiotherapy there or he had a radioiodine therapy, I don't know what treatment he got, those are the patients. They later on go on to develop other tumors as well. So he may not be thyroid, but may have another occult malignancy. And that could only be detected by a very good, reliable PET-CT.
Can we suspect that the cholesterol is normal? Can we add to that list
amyloidosis? Absolutely. But amyloidosis would have been picked up by the Americans. If they didn't, then that bloody
if they done congruent.
if those guys missed an amyloid on this biopsy, I would just personally go and shoot those people. So that is not possible. But you're right. But you're absolutely right. Which where cholesterol is normal. And that would.
Shouldn't that be the function of the staining? If the staining was not there, how could you just see it? So
if somebody missed the staining on the original specimen, because
I'm
not defending any, I would put those words in the comma, American pathologist, but if the staining was not done appropriately to begin with, and if the SPEP, UPEP, or those studies are not done as they should be done, I think you can easily miss this diagnosis.
And that's what Arif was saying, that it's not done at the site of biopsy. The preparation, biopsy is all in the preparation. It's not in the eye of the beholder, it's in the person who is bloody making the slide. So you're right. But having said that, amyloid to be mistaken, even on light microscopy at normal...
That's a criminal act. I agree.
So I think what Professor Azad Mand has said is that it's amyloidosis. And if you look at it, there are two main causes of amyloidosis. One is myeloma related, which is cancer. And another one is because of chronic inflammatory condition, and they got to be malnourished. And they have got a lot of cytokines, which is TNF, IL-1, and all those things. And that keeps the cholesterol low. So the mechanism is the same, whether it's malignancy or chronic inflammatory or myeloma. Cholesterol tend to be lower. And whatever the underlying etiology, you can tell, or at least get a vague idea that I am dealing with a straightforward nephrotic syndrome. And in the cholesterol, and you can add cholesterol, it's not that difficult.
I don't remember the cholesterol, but I think it was on the high side. It was just like full picture of nephrotic syndrome, just out of my head right now. The American pathologist just did comment it was a very well preserved biopsy specimen.
Your skill is unquestionable. I don't believe the skill of the people for after your hard work. I honestly think that you are one of the best clinicians around in the world, not only in this country, because you see so much of pathology. And your skills, your eyes, the way you see and take the history is fantastic. But in modern times, as you know, that when I was at house, the boss would say, this is it. And I couldn't question because there was no way of proving or disproving. Because there was no already test available in Pakistan at that time. And those things have not got better, despite improvement in our healthcare. Because the people where we should be focusing now is on the diagnostics. I think you guys have taken it to the level where you can't take it anymore. You need help on the diagnostic side.
Okay, so I think that was a very, very good case. So I think we have some idea where to go from this. So one thing is, one way would be just wait for 3 months with the steroids, think about rebiopsying, look at the selected protein, urea, and we can take it from there. Yes, excellent. And maybe a PET CT as well, and read by someone who knows what he's doing. Okay. So moving on to our second guest speaker. So he's got so many affiliations and he moves around so much, so I keep on forgetting. So the last time I saw him, he was a professor of nephrology at the University of Miami. Since then, he moved to Albany, then thought about doing an MBA at Harvard, and now he is the clinical director and professor of nephrology, and rather the clinical chair of medicine at the University of New Jersey, probably. So yeah, so he is a household name in the world of nephrology. He's done wonders in nephrology, and I'm proud to call him my friend. So Professor Arabas. Yeah.
Assalamu alaikum. सबसे पहले तो अस्सलाम वालेकुम एवरीबॉडी मैं शुक्रिया अदा करना चाहता हूँ PSN का ऑर्गेनाइजिंग कमेटी का प्रोफेसर वकार का और प्रोफेसर एजाजमंद का कि मुझे दावत दी है यहाँ आने की और यकीन करें कि मुझे इतना मज़ा आया इस दफ़ा आके क्योंकि इन्होंने मुझे जिस तरह से इज़्ज़त दी है और जिस तरह से ट्रीट किया है आई एम रियली फ्लोर्ड. जैसे मैं कह रहा था, I agree with Umar. Thank you so much for inviting us. This has been a great trip so far. I wish that we didn't have this situation. It would have been a great meeting, and unfortunately we couldn't get that. I'm also thankful to be included among the icons of Pakistani nephrology and the United States and England. कि मेरे जैसे शख्स को ये मौका मिला है कि मैं यहाँ खड़ा होकर इन लोगों के साथ मिल के इस कॉन्फ्रेंस में प्रेजेंटेशन दूँ. बहुत बड़ा एजाज़ है मेरे लिए. मेरे वालिद साहब 2009 में अल्लाह को प्यारे हो गए. उनका ये बड़ा दिल चाहता था कि मुझे देखें लेक्चर देते हुए, मुझे देखें दुनिया में मुख्तलिफ जगह पे बोलते हुए, और मुझे कहते थे कि एक दिन आएगा बेटे कि तुम ये करोगे. और मैं सोचता था कि ये तो मुमकिन है ही नहीं, इससे ये तो कभी नहीं हो सकता. ये कहते हैं कि मेरा बेटा ये करेगा, मेरा बेटा ये करेगा. मैं अंदर से शर्मिंदा होता था कि मैं इतना अच्छा स्टूडेंट तो हूँ ही नहीं, ये कैसे मुमकिन है. लेकिन शुक्र है खुदा ताला का, उनकी दुआओं से और मेरी माँ की दुआओं से इस जगह तक पहुँच गए कि मैं आज आप जैसे लोगों के साथ बैठ के खाना खाता हूँ और आप लोगों के साथ डिस्कशंस करता हूँ nephrology related issues. My talk today is going to focus on one aspect of nephrology, which is interventional nephrology, vascular access care. I believe it's very important. I believe it's part of nephrology today. So that's what I'm going to talk about. This is the center where I work today. I was at University of Miami for 15 years. I started my fellowship there. I became an assistant professor, then associate, then full professor in 2009. I was the youngest professor in the history of the University of Miami when I was there. I left University of Miami because I wanted to do more, and I wanted to achieve more for my patients and for my country. I went to Albany Medical College. I became the chief of nephrology and hypertension there. And then I realized कि मुझे कितनी चीजें नहीं आती. उन्हें सीखने के लिए I went to Harvard as another angle. How do we manage diseases, not just one disease? How do we pay for things? And how do we provide care to patients in the most cost-effective manner? So from Albany, I ended up going to New Jersey, Jersey Shore University Medical Center. And I am going to start my presentation by taking you back to 1966. This was the year when, for the first time in the United States, in the New England Journal of Medicine, a paper appeared Dad said that we have created an arteriovenous fistula for the first time. I'm sure on the planet, I'm sure here in Pakistan and in Latin America and in Europe. Probably someone else created the fistula, provided dialysis. However, this is for the first time that we saw a publication, somebody documenting the event that we have created an arteriovenous fistula. His name was Michael Brescia, and I talked to him in 2003. I've told this story before, and I'm going to say that story again. I was sitting in my office in Miami, and I was writing a paper about the creation of arteriovenous fistula by nephrologists. And Junaid was in Phoenix, Arizona. He was asking me that, have you created arteriovenous fistula? Because he probably came across publication by me indicating that we should do that. Nephrologists should do that. While I did not create the fistula, I brought the concept back in 2003 to the rest of the planet, indicating that I think we should do it again, because this man did it. So I was in my office. I called my secretary. I said, Elena, can you find me Michael Brescia? His last address is Cavalry Hospital, Bronx, New York. Elena, my assistant, and she was very good. जब भी कोई बंदा ढूंढना होता था, I would call her and say, Elena, can you find me this? And she would find always that person. This was 1966, so मेरा ख्याल था कि he probably would be dead by then. This was 2003. So I played a joke on Elena's thing. She'd come back and say, I can't bring the dead people back. So around 4 p.m., she calls me back and she says, Dr. Asif, I said, they call me Asif. So, Dr. Asif, I said, yes. She said, I got Dr. Brescia on the phone. So I said, Dr. Brescia. Okay, I'm sure there's another Brescia from New York. So I picked up the phone and I said, hello, this is Dr. Asif. And he said, yes, Michael Brescia, you had paged me. I said, yes, are you the Michael Brescia who created fistula in 1966? He said, yes, what did you think, I was dead? I could hardly speak, so I started talking to him, and I invited him to a meeting, and this was the meeting in 2008, Salt Lake City. And I asked him, how did you think of creating an arteriovenous fistula? You combine a vein with the artery. That's a malformation, right? Remember physiology, congestive heart failure would happen. So I said, why did you create a situation like that? And he said, I didn't. I was taking care of patients who would come to our emergency department, Vietnam veterans. Often they had bullet injuries, and bullets would land in the pelvic area, hitting the femoral artery, combining the femoral artery with the femoral vein, creating a fistula. And none of those patients, he said, had congestive heart failure. So I started thinking that if they can have arteriovenous congestive heart failure, I could take a small artery here and combine it with cephalic vein to create an arteriovenous fistula. And he said, that's exactly what we did. We had 15 patients, he told me. And he said that I can't tell you, all over the world, people from Europe, people from Latin America, celebrities from California, Hollywood, everybody with renal failure was flying into New York City to get the arteriovenous fistula because we had that Belding-Scribner shunt that would have lots of problems of coagulation and so forth. So fistula was an overnight hit. Everybody was coming into New York City. That's my conversation with him. So what happened to us? Why did we go away from these procedures that we created? He was a nephrologist. He was a renal doctor. What happened was dialysis. You have to know the history. 1980s and early 80s and late 70s and late 80s was a period of major boom in dialysis industry. Dialysis became a reality on a mass scale. Research, financial centers getting a lot of patients of renal and renal failure drove that train away from these procedures. So these procedures were then delegated to surgeons. They took the arteriovenous fistula, radiologists performed the intervention, and then we kind of slowly drifted away from these procedures. Fast forward to 2001. This is when I had completed my fellowship at University of Miami. And we were faced with a situation where, I'm sure it's a similar scenario here, that you have a dialysis patient and you send them for declotting and patient comes back with a catheter. You send them for a catheter doesn't get placed because they're so busy. You ask them to create a fistula on this side, patient comes with a graft on the other side. Those were the problems that we were faced with, and I wanted to do something about it. I wanted to build a team. I wanted to create a program that relates to dialysis access. And this is what we did. I met with a few leaders, Steve Ash, Ted Saad, Tim Flutter, Gerald Beathard, that you're all familiar with. My friend Tushar Vijayjani, and radiologists, two radiologists, Sandy Altman and Tom Besser. And we said that we need to formulate a society. We need to bring people together. We need to train. We need to have curriculum. We need to have an entire platform where nephrologists would perform these procedures. We're not going to wait for others who are not providing us the service that our patients deserve. You can either wait and you can either beg, or you can stand up, learn the technique, be good scientists, collaborate with people, and do it yourself. That's exactly what we did many, many years ago. And the rest is history. I'm going to share a couple of procedures with you, basically steps of the procedures. I'm not going to share studies here. I'm just going to show you how the procedure is actually done to make the point that anybody in this room, I guarantee you, anybody in this room can do this procedure. It's not rocket science. It's a very simple procedure. So these are the two problems. You have most common problem is a stenosis. That within any dialysis access, you have a problem that vascular access stenosis occurs. It can happen in arteries. It can happen in the veins. And this is the procedure that we do, one of the most common procedures to take care of dialysis access. Here's the arm of the patient. I'm going to orient you. This is the elbow. Here is the shoulder of the patient. This is the left upper extremity. The neck of the patient is up here. So you're oriented. This is the elbow. This is a brachiocephalic fistula. So you take this and you give simple local anesthesia on this site right here. And then you take a micropuncture sheath, micropuncture needle into the fistula, just like you're placing an IV line. Following this, there's a plastic special catheter that you feed on top of the wire into the fistula. Right, you see on the screen. What's that? Yeah, I can't change the mouse here. I got it. So take a look at this. This is the cannula. Here's the micropuncture wire. So you take the cannula over the wire, you insert that into the system. Now you can put a simple 5 cc syringe on top of this. You can put contrast into it. You can have a camera and that can record images of this particular patient. You saw the arm here. You have a cannula. You take a syringe here. Camera is up here. So nothing special here. You put this into the vein. You put a syringe here, 5 cc contrast. Inject the contrast while you press the button. Here, thank you. All right, So you inject contrast into this, and you can see the entire system, and this is how it's going to look. So here's a upper extremity fistula. Humerus is shown here. This is the cephalic vein coming up here, and you see the tight stenosis here, right? Anybody can see that. What's the degree of stenosis? You look at the vessel before the stenosis and after the stenosis. This is at least 90% stenosis. What do you do with the stenosis? Now you need a little bit bigger sheath, a bigger catheter like this, a catheter that has a port for the wire and it has a port to inject. You put the same catheter into the axis, you put a wire through it, you send the wire across that lesion that I showed you, the wire sits across the lesion, and then you take a balloon. It comes on a catheter. Here is the balloon that's already wrapped. This is contrast. Once you release this, contrast is injected through this catheter into the balloon, and then you can inflate the balloon. You put the balloon over the wire, through the sheath, into the access system, and you take the balloon all the way to the site of stenosis and you start inflating the balloon. Notice that the wire is still there. This is the position of the wire going in. Yet your balloon is on top of the wire. You inflate the balloon. It shows the defect. The gun that I showed you before has pressure in it. You can measure the pressure here. Keep pressing this until you reach certain pressure and until you totally inflate this balloon like this. So this should show you that either two things happen. Either you punctured that site of stenosis or you fixed it. And how would you know about the two? You have to re-look at the image. And with that, you have to put the contrast back in and run it through the system. This was before, and this is after. And you can see that the stenosis has been fixed. Contrast is running into the central circulation easily. This is a very simple procedure. Unfortunately, we didn't have the workshop. Otherwise, I would have demonstrated to you how easy it is for you to perform this procedure. Even residents can perform this procedure. My fellows at University of Miami, at Albany Medical College, were doing this procedure 15 minutes a pop. Here's the stenosis I showed you before. This is after. We reviewed some of the images here with Azhar and Harun at your lab. And I was blown away to see that every single patient had stenosis in the central circulation. The central circulation was shot. Once you have central venous stenosis, you really can't use any arm. You can't use the right arm or you can't use the left arm to create a fistula. That person has no lifeline left for you to dialyze them. So central stenosis treatment is very important. You could also perform this angioplasty to fix this lesion. Here's the neck of the patient. Head is up here. This is the left shoulder. Access is coming through here. The superior vena cava, and you see a tight stenosis right there at the junction of the brachiocephalic with superior vena cava. You perform the same angioplasty here. It's somewhat better, but not perfect. You can go back in. And this is the post-angioplasty. The lesion is almost completely gone, and the flow is restored into the circulation. Think about a patient who had this scenario, and think of you performing this procedure to help your patient. This is a comparison. This was the beginning, and then we fixed it with the balloon, and then we finally reshaped the superior vena cava. Here's another patient with the complete stenosis of superior vena cava, bilateral supraclavicular swelling, facial edema, shoulder swelling, extremity swelling. Look at the arm. The axis is on this side. She had a catheter. Because of the catheter, she had all these problems. And this was my patient. This is the image of that patient. Neck of the patient is here. Head is up here. This is left shoulder, right shoulder. Look at the catheter going in to IJ, the brachiocephalic superior vena cava, complete occlusion. only catheter is going into the atrium. You can't have even a drop of blood going through the superior vena cava. What would happen to this patient? Nothing if this catheter got infected. She does not have a lifeline to receive dialysis. And to fix this situation, you put a wire through the catheter. So this was the catheter. We put a wire through the catheter. The wire is going down into the atrium now. We put a balloon at that site, dilated the balloon to fix the stenosis. Look at all the collateral circulation here because traffic is not able to go in this direction. It's heading back. Once the balloon angioplasty is performed, all the collaterals have disappeared. This patient's edema improved markedly, and she was able to get dialysis through that axis. Again, the power of a very simple technique, very simple procedure that you can see that, that can help your patients. These are the accessory branches that you can ligate. These also using balloon angioplasty, and Junaid's program is the one that kind of came up with this idea with Rick Mishler, who described this technique for the first time. You take these coils, they come loaded into this system. These are the side branches that are creating problems for the fistula. Fistula is here, but you have a side branch here. It's stealing blood away from the fistula, and another one. You can selectively cannulate these. Bring the catheter, put a coil into this, then another coil into the other blood vessel. This is before and after. You have taken the side branch out by this coil, and another coil has taken this side branch. And you have one simple place where you can put needles into the fistula to dialyze the patient. A little bit about stents. They're very expensive, about $3,000 a piece. They help in certain situations. However, I believe that there are problems with those. I think, one, they're very costly. Two, there are nidus for infection, and I've written about those that they cause major infection and perhaps not a good use for them in dialysis access. Only when you have ruptured something you should place these type of devices, and perhaps in the central circulation. All right, I think this is, I just have a couple more slides left. I just wanted to kind of bring you back to the technique that if you want to develop this, I think the next thing along with this is develop a registry, database that you can publish on and what you can share with others, as we did when we were developing these procedures and techniques. We defined the area, we wrote the first textbook, we wrote the second, we wrote the third textbook, and now we're in the process of writing another text to share the knowledge that we have gained with the rest of the planet and the rest of the country to develop their programs. I have the honor of helping so many countries bring up their own interventional program. I was in Singapore. I helped them. I helped Australia and France and so many other countries get their programs. And I think the best way to do that is by collaboration. The next phase for interventional nephrology, and for you if you were to develop it, that specialty, is to team up with scientists like we did, scientists like Professor Magdi Yaqub, to kind of find out why do we have this stenosis? Can we block those cells from proliferating and stopping those, to stop the neointimal hyperplasia? And develop the surgical and nephrology teams together to create the best fistulas and then maintain them as we go through the patient's dialysis years. I want to stop here, and if you have any questions, I'd be happy to answer those.
Literally, this was an honor listening to what nephrologists could actually do. But it was really a pleasure. But the only problem here is, considering the fact we don't, Either we could stand up or we could beg the surgeons to do the job for us. Now the thing is, there is a possibility that we might puncture the stenosis while we are actually deflating the balloon. So if something goes wrong in that way, what would you do?
Yeah, for that, the first thing is that you have to train, right?
Yeah.
You have to receive the adequate training.
Yeah.
Once you have trained, then you got to be prepared to handle those emergencies.
Yeah.
When you manage cases, for example, the last case of membranous that was presented of proteinuria, there are times things don't work out. Mm-hmm. That doesn't mean that we stop. We come up with scenarios to handle those. You should definitely have a team that should include a surgeon in a program like this. But your point is well taken that, what if there was a rupture? We should consider what ifs, and we shouldn't shy away from them. We should face them head on.
Sure. Well, that was my question. Thank you.
I had a question. So, Arif, being in Phoenix, as the doctor mentioned, perforation was not an issue. You had a covered stent. But when I come once here, you find out covered stents are a big deal. They're a big cost that sometimes may be hard to accommodate. So what are your thoughts on using bare metal stents? Have you used any?
I have. A good question. I think in perforation, if you have a covered stent, it's better. However, I have placed bare metal stents in perforations, and
you have?
Yeah, and I found that it helps also.
Okay.
The biggest thing that helps is leave the balloon there for a minute.
Sure.
It's like holding pressure from within.
Right.
It's the cheapest thing, and you don't have to spend $3,000 on a stent. Right. Just leave the balloon there, deflate the balloon if they're still bleeding, inflate it for 1 more minute, and then let go.
I see.
Yeah. And ultimately, if all goes bad, you have the option of just holding pressure and closing the fistula.
Thank you.
So my question is, what are the chances of a re-stenosis after balloon angioplasty?
Yeah. Recurrence is very common. Recurrence is common. So one patient will have at least 1.5 recurrence a year. So you should plan on having them on some sort of surveillance if they come back to your lab and you maintain their fistula. You'd say that, look, what's the ultimate fix? There's no ultimate fix for anything. You saw the case of proteinuria. Things come back, you have to address them. And maintaining that fistula is worth something. What if you've maintained a fistula for 10 years for a patient, same fistula, same place, no central stenosis, you're performing balloon angioplasty? I think it's worth it. I should mention the cost of the procedure. I was speaking earlier with someone, and the cost was being mentioned as $400, $500, $600 for a balloon. I think that's too much. Even in the United States, the balloon costs about $80 to $120 for a normal balloon. Not for a Conquest, that would be very expensive. But you don't need expensive tools. And I agree with Professor Magdi Yaqub that we've got to simplify things. We've got to use tools that work and are effective. We don't need to go for Cadillac. We can take a Toyota Corolla and that should do okay. So $80 to $120 balloon is just fine.
Arif, thank you very much. How would you guide us to set up an interventional nephrology program? That's we talk about it many times. You need Naman, you need courage. You need courage. Okay, that's the most important thing. People shy away from taking bold steps because they feel that you have to take that step, and courage is what's needed. And I think Professor Wakal has taken some initial steps. His plan of this possible workshop that happens, if it happens in the future, will start the seed here at this institution. If that were to happen, think about it. You only need one center to actually take the lead. The rest is going to fall very quickly. That's exactly what happened in the United States. We started at University of Miami. I brought people. I started training people. Instead of holding it to me, I brought everybody and I said,
come to our center, we will train you, and then we were releasing them back to their centers. Not everybody was being successful at their own particular center in gaining the privileges, but many were. And today there are many centers in the United States working on interventional nephrology. Junaid is here now. Junaid के पास बहुत experience है, ये बहुत अच्छे level के interventional nephrologist हैं United States में. I have read his papers and learned from them. He's a solid guy. He's here. There are many others who are right there now thinking about it. Siklan, I with him in the United States में, and we sat in our hospital and I shared some of the tools with him. So I think things are right there at the cusp of you starting it. If there's anything I can do to help you, of course, I'm in.
So, one more thing. I think it was such an elaborate and an eloquent talk. Thanks for being here, sir.
Thank you.
And I love the example from the Cadillac too. So, talking about that, if we don't have a cath lab, is that for vascular scan or a fluoroscopy, would that be helpful in doing something to start with?
Yeah, so you need a fluoroscope, but you don't need that big fluoroscope of a cardiac cath lab. You can take OE 9600, I don't know what models are available here. When I started it, everybody refused, by the way, in the United States at University of Miami. They said, you can't come to cath lab. We know you're trained. We're not going to let you into cath lab. We're not going to let you into surgical ORs. So I leased a fluoro from the company. And in my dialysis unit, I made an operating room within the dialysis unit because you could do that with a small fluoro. And I did 100 cases, and I showed the university for 100 cases, this is the amount of money you made, this is the impact on the patient. Do you not want me to do this? And they said, sure, we want you to do it.
We would have loved it. Yeah. So one last thing, I think it's something different from the topic that is under discussion. Regarding tunnel double lumen catheter, if you don't have a fluoroscope, how would you proceed with it?
What's the need? If there's need, I would proceed without fluoro.
So, in general, tunnel double lumen catheter is part without that fluoroscopy help over there in your center?
In the United States, no center right now places tunnel catheters without fluoroscopy. They should not do it. However, this is not the United States, so resources are limited. If the resources are limited, you go back to what Professor Magdi Yaqub said. You have to rely on your knowledge of anatomy and your landmarks and your existing techniques like X-ray. You're placing temporary catheters, aren't you?
So we are also doing the tunnel double lumen catheter with the surface anatomy that you're talking about. But I was just curious about what's the long rule over there.
Over there, no, you can't. You have to use ultrasound and fluoroscopy because we believe in zero complications. If you don't have the resources, I believe in providing something to provide dialysis. Does that answer your question?
Thank you.
Yeah. Thank you.
That was a wonderful, wonderful talk. One thing that I would like to admit that, yeah, so we will be having this conference in October, and rest assured, if you say yes, the conference will be taking place. Okay. Yes, and you will be invited with all of us. Yes. I'll be here, and even if you say no, we know now your secretary's name is Elena. Yes. So yes, and she knows where he is. Yes. Second thing I would like to admit is that it's quite unfortunate that we're sort of sitting on a gold mine, which is Dr. Junaid, and we don't know much about him. Yes, he's at PKLI. And he's a lead guy in interventional nephrology. So I'm pretty sure that we can get him across, involved in the PSN as well, and we'll make you good use of him. Yeah? Pleasure. Okay, excellent. So moving on to the final talk, which nothing to take away from you, but which probably will be the highlight of this conference. He is a professor of translational medicine and a professor of nephrology at the University of London. He's the director of the William Harvey Research Institute, and I am humbled that my supervisor was Professor Azman, but I am indebted to Professor Magdi Yaqub that I have had the pleasure of working under him. He's been my supervisor during my stay in the UK. So he's been very kind to us, and he has been very inviting, as well as he's accepted it with open heart to talk to our residents today. So I can ask you to please come to the dais. Yes.
Thank you very much. Ahad, of course, you will always be very close to my heart. And before I thank everyone else, I would like to say that it's always very, very pleasing to have a very good ambassador from the country you're born. But when we had you in my unit, it's my reputation online as well, to some extent. And it's more if a person from India does something wrong, then it's less painful. But if a person is coming from Pakistan and is not up to the mark for my unit, when they come for training, and I've had quite a few people from Pakistan who are, alhamdulillah, been trained in my unit, it's more painful. So I'm very nervous when I get people from our own country, because everybody knows that I was born in Pakistan, so in order to avoid the label of nepotism, that I'm supporting only my own people, I have to be whiter than white, and in order to do so, I in fact pay much more attention to getting a caliber people from Pakistan as compared to the rest of the world. And I can say about this boy that he has made us proud, and still today, my colleagues remember him and they send his regards when I came here. So you have got a gem here. First of all, I would like to thank Waqar, obviously the organizer of the president of PSN. Ejaz Mand, I think he just had to go somewhere. And these people were my host last time when I came. It was 4 or 5 years ago. This is my second time to Lahore, but in between I have been to most of the other cities in Pakistan. And whenever I come here, I always spend quality time with the trainees. So this is my passion. Because I definitely a history, and possibly my other colleagues are going to be history soon. You are the future. We need to invest in you guys. And really, even at the end of this presentation, I can inspire one soul in this audience. I would say to myself that I've done my job. And that's what, when I go on the road show and just come back from Kazakhstan and China and Hong Kong. That was my last month rounds there. And I always go and talk to the trainees, and so you guys are the future, believe me. And you are at a time in biomedical sciences. I hope I am alive to see some of the things which I can tell you would happen, and what we are already seeing the beginning of. It is going to take, you guys are going to practice completely different medicine than what we are doing it today. So be ready for that, and you need to be taught the same way in medical school. So just start from my own experience. So yesterday we were, taken by Ahad and all the other organizers to many renal units. And first we went to King Edward's, which is I would say the landmark institute in Pakistan, let alone in Punjab. It's the oldest medical school in Pakistan. Though built before partition, but still the oldest medical institution. Then we went to Jinnah Hospital, another superb hospital. These were two government institutes. And then we went to Pakistan Kidney and Liver Institute, which is yet not fully operational, but the beginnings tell us that it is going to be a state-of-the-art facility. And I wish them all well. So we went through this, and I was saying to myself that when, for my personal level, I left Pakistan in 1982. And my mother passed away, Asif, like your father. My mother, I had to come and visit my mother, no matter what was the case. Mother comes first. And then also, I think, a message for the trainees that when my mother passed on, that magnet gone, so the metal frequency diminished. So every 2 years, 3 years, 4 years, and it became very, very less frequent visits. And even when the visits happened, they were flying visits over the weekend. The whole family is now dismantled, everybody is everywhere else. So our elders, and by that I'm saying not only your parents, but remember in our religion, after your parents, the person who take over your parent respect is your teachers. So when these teachers go away, there is a vacuum and void, and we need to get you ready to fill those voids and do the same footsteps that these people have done to this society. When I used to visit it, being a scientist at heart as well as a clinician, I would always see that how this society is evolving. And during the first year, I was just mollycoddled. My mother wouldn't let me go anywhere. I would be just taken from one place to another. Law and order situation was not very good. And so I didn't see much of what was happening in the society. And for me, the society stopped. Or Pakistan progress in the societal terms stopped in 1982. So I was dreaming that Pakistan is exactly the same as I left in 1982. Nothing would have changed. The girls dress the same way, the boys dress the same way, they eat the same sort of a thing. They still sit on the street on the Sunday and Saturday, and they're playing the golia, or they're just throwing some dirt on somebody passing, the mazakis. That was the time which I left, and that has, for me, never changed. But this visit, I was privileged that I've come with my wife, who is also a doctor, and I went to a few of the shopping malls. And first of all, that is the first time I've seen your shopping malls, and first time I realized that, God, Pakistan has progressed in non-medical field, but in other areas. So you go to Packages Mall and Emporium malls, and say, God, they are as bloody good as British or Dubai. So there's some progress there. But something I also noticed that the dress sense has changed, the type of cars which were parked have changed, the girls and the boys, the way they talk. I saw a lot of young couples with a hand in each other, which was frowned upon when I was growing up. So I just thought that, God, the West here, and the virus has come here as well. This virus is spread. Then I went to King Edward's yesterday, and they showed me the medical school. And I was horrified. And I was literally could not speak. When they showed me the same anatomy dissection hole, the same bloody physiology lab with smoker's drum, some heartbeat in the center. And I was just standing there and I said, God. And then they showed me a Department of Forensic Medicine, hygiene and something like that, which are still the full-blown subjects, which are taught as part of, and if you fail forensic medicine, you fail the bloody year. That's sort of a... And I just, honestly, it took my breath away that my medical students don't do anything like that. We have walked away from all those things. My medical students don't have anatomy dissection. They've got 3D models and they just practice their anatomy on that. Or in a much shorter period of time than what you spend 2 years of your time doing anatomy dissection, which by the way never becomes useful. Even Asif would not need the level of Gray's anatomy which we were taught to bloody ratify when I was a youngster. How often you need those emissary veins, names, etc.? You just need some landmarks. So all this rubbish is still going on in our medical curricula. So the first thing which I would like you to do is that when you grow old and you become a trainer yourself, that all those who are already in some influence position, that let's start the future from now, that you have to change your medical curriculum. the emphasis is on bad things. So I'm just giving you example of my medical students, because I teach a lot there as well. And I made few notes that what do they do to prepare them for the 21st century. Right? That is the one thing which that I need to show you, that what sort of a medical thing they do. So, my medical students don't do forensic medicine. They don't do hygiene or whatever. But they pay more attention towards medical statistics. So I'm getting them ready to at least interpret the clinical study rather than accepting my word or Asid's word or Farooq's word. We can say whatever, but at the end of the day, detail is in that statistics. And how often that statistical analysis was taught in the medical school to me? Never. I didn't even know. I learned all that myself when I went to the West. And that was the first thing I realized, that though I can be a position holder or whatever, I had a handicap that my training was inferior to a medical student who was doing a house job with me when I went there in 1982. They are even much smarter now than what I at that time. Most of the medical students would take a year out and do BSc. So their course is not 5 years, their course is 6 years. 1 year, and that 1 year they take it out from the study. They don't go to the lectures, nothing is happening. They come to either my lab or many of my other colleagues. We select them by interview procedure, and during that 1 year they do BSc by dissertation, they do research. So there's another degree they do. So when it comes to on the clinical floor, they are 1 year, they are 1 year senior, but they are also 1 year ahead of you. That 1 year of maturity working in a lab, or it doesn't have to be lab, they do epidemiology, they learn about meta-analysis. So one of my areas is meta-analysis, so they come to my lab, I teach them about meta-analysis, they get some publications, how to write. All those things are preparing them for what lies ahead for the future. I don't know whether that level of teaching is going on in this country or not, but those are the things which we have to do. We have got artificial intelligence lab. Right? We are not still even working. A day will come when you are youngsters that robots will be doing the, dialysis for your patient. There won't be any nurses. Your clinic attendant would be a robot. Person will come and ask that robot who will be multilingual. You would have programmed him how to talk to your patient rudely or very dignified way, whatever. That person is going to do it. It's already happening in many other fields. We will get ready for that. All those things, my students are already getting in artificial intelligence labs. They are analyzing your histology. And we are teaching our computers now. Because that's the easiest. Radiology and histology are the two easiest things for computer to learn. So when the histopathologist is reporting, the computer is automatically recording that how he is reporting it. And after a certain period of time, you just put the slide in the computer records, and then the histopathologist checks that whether what he is saying is correct or not. This is the future. But my students are already learning that. So when you come to UK, and you are initial, first, second year medical, house officers, etc., you will be up against a student who will be doing the same job as you. You can see the difference. But I don't want you to disappoint you. Yes, you're much smarter in many other ways. But I think that we need to change our medical curriculum. That there are many other things. We need to prepare our future workforce, our doctors, to learn about primary care. So let's talk about primary care. How a patient in United Kingdom, which I still think, though my American colleagues may not believe in, but I would say that having worked in America myself, having worked in Canada, having gone to Singapore and spent some time there, I still can say that British NHS system is the best and the fairest healthcare system in the world. You just pick the phone, 999, an ambulance will come, you get treated, and you go home. Nobody will ask you which insurance you belong to, how much money you make, are you the king, are you the Maharaja? Nobody will ask you. All they can do is free. It's the taxpayer who's paying for it. That is the biggest reassurance anybody can get, that everything is free. So I've got the test. And the backbone of that system is primary care. So if I see a patient for the first time, this is what happens. I'm just describing. A patient would come with nephrotic syndrome, what happens. Right? And that patient will just not turn up at my A&E, or he would not just come without seeing anybody else, or having seen anybody else, he can hide that I have spoken to Mr. X. He will just hide that fact and see what I say. That is all possible, isn't it? This is particularly very common in a culture where we are, second, third, fourth, fifth opinion, and they're doing all that so that they want to hear what they want to hear. They don't want to hear the truth. Having said that, that doesn't happen in the UK. That patient would have come by a GP, otherwise he can't come and see me. And GP may write 2 lines on his referral letter that, would you please see this patient who has got proteinuria? He comes in my room, I tag in his NHS number and click few icons, and I can go into GP record, any other hospital he has been to, any investigations he has had in United Kingdom is in front of my computer. I can see everything, what has happened, to the extent that I even know how he was vaccinated. Because the record goes, the first registration, the patient does not get NHS entitlement when he or she is born after the birth certificate issued by United Kingdom. The second place they go to is the GP, to find a GP, to get registered with the GP. And that's why the family practitioner came in, because those GPs have been looking after the families and families of people. And every GP is paid by the United Kingdom government, and they need to have anything between 1,500 or 2,000 patient size. They can't have more than those number of patients under the list. They are responsible for everything, prevention, everything. And they don't get paid if these so-called guidelines which we have created, they don't abide by it. So if somebody's cholesterol is more than 5 in their practice, they are, say, 1,000 patients. If they are not on statin, in 90% of the cases, they won't get paid. So these have been now put, reimbursement targets. So prevention would happen at that level. Prevention would not happen at secondary level. Prevention will not happen at tertiary level. Prevention would, if I want to go and find out how many patients in East London where I practice have got hypertension, I have to go to EMIS, which is the GP database. I put 2.5 million people, click adults, which will give me any patient above the age of 18. For us, 18 or above is adult. And then I put hypertension. The question will come, what do you mean by hypertension? That is, I have created. I find definition of hypertension is the easiest. I find the definition of normotension the hardest. What is normotension? You can say, the bloody guidelines would say 130 over 80, they keep changing. Sprint trial came and it's now 130 over 80, everybody's talking about it. Right? They were all generated in the West. So when I became a consultant, very junior consultant, I went through a phase of biopsying every microhematuria. Maybe because I was very, and I'm still arrogant, I would be very honest with you, you would know that I'm a very arrogant man. And when I'm in the room back home, nobody breathes, so I'm not that jolly. I did it. I stopped at 21 because I liked the age of 21 when I was 21. And it showed nothing. And then, you always do it, and then you screw it and you set. And I said, why did I do this? Anyway, and I sat with my histopathologist, who was also a consultant, he's now a professor. We both sat together, and we went through all those 21 biopsies with full clinical record and full biopsy, only him and me. No glomerular lesion, nothing. The only thing we found was that every one of them had hypertensive change. Now we are talking of this young men, many of them were young Bangladeshi women. And I wanted to know why they are happening, because we in our Bangladeshi community in England have got high incidence of unexplained renal failure, undetermined CKD, small kidneys, they can't biopsy do, it's all ball-to-wall fibrosis. I said that if we were to do biopsies much earlier with normal renal function, normal tension and microhematuria, is this the first sign of something which will happen in future? I wanted to. But when I looked at it, the blood pressure of most of them was 120/70, 122/78. By the way, the mean was 124/78, and I think most of us will be proud of their blood pressure control. So they were normotensive. Were they normotensive? And I did. And found out that in Bangladesh, where most of these girls came from, in Sylhet, with that age group, the blood pressure in that village is 90/60. So this was hypertension for these women. So that's why I say that we practice evidence-based medicine in Pakistan. That's fine. You need to generate your own evidence. All the evidence in every discipline, in cardiology, in nephrology, in gastroenterology, has come from the West. The blood pressure of 130/80 in a 40-year-old in a 40-year-old woman in America would be normal. But it may be hypertension in Pakistan. So you will have to devise new guidelines for your own local population, that what is the normal blood pressure. And in order to do so, you need to be prepared to do your own research. Research is not a luxury. Research is to improve yourself as you are going along and learn from your own experiences. We call it audit. That I always do the audit of my thing, that I did 5 patients treated this way and see whether they were. This is not, it is research. You're already doing your own personal evaluation all the time. And that's what I'm teaching the training. That you need to not believe me, not believe what I have written. That is all based on the data for the West. Tell me, first of all, that is there any study? Give me one study of substantial size which shows that ACE inhibitors are equally good in Pakistani community with diabetic kidney disease in a proper prospective randomized control fashion. By the way, ACE inhibitors in kidney disease, proteinuric kidney disease, are now taken to the level, now Zubillah, they are like Quranic verse. You can't change it. If you talk against it, there will be 5 bullets coming towards you. Based on a total group of people, I'm talking of ACE inhibitors, which is class A recommendation. CKD, proteinuria, either diabetes or whatever, your first line of drug should be ACE inhibitors. This is all of you know possibly. You know the total, if you do a meta-analysis, it is based on 2,200 patients who participated in randomized control trials. 2,000. Primary renal disease. I'm not talking of the diseases in which they just use a post hoc analysis being CKD as like target studies and what. I'm not talking about primary kidney disease based on. And now we say that 10% of the world population has got CKD. And our evidence based is derived from 2,200 patients who were part of RCTs, from which we now say and go and collect air miles by many of my colleagues. They are always in the bloody air. They're never on the bloody floor because they've never seen a patient. They don't even know what the life is like, real life. They go and write guidelines, and they say that ACE inhibitors is good based on this evidence. And they come to Pakistan and will say the same thing. But you know that in Pakistan we don't even know what is the pathophysiology in the face of excessive sweating, the amount of salt we eat in our bloody food. Will these all things, taking all those cultural differences, would ACE inhibitors be equally good in our patients or not? You need to find it. I can't do that. I can teach you how to do it, but I'm not going to come and do it for you. I will tell you when to cross the road. I am not going to take you on my back to cross the road. This is what we call collaboration. This is what, when you come to get training under my, this is what you will get. You will have to run, then I will walk. You have to demonstrate that you are capable and you believe in the philosophy of self-improvement. Every day you come, you ask why I am doing it. And you are in the best position to ask this question. You can get away with murder. Now, you will never do it, but if by a mistake your patient died, you were a trainee. The whole problem lies with me. I will face the music. That you left the trainee alone and your patient died, I will go in front of the GMC. There will be an accountability. You guys are at a stage where you can come and say, sir, why are you doing this? So, that is your job. Self-learning. And unfortunately, when it comes to learning, you learn in every other aspect of your life. How often your father tells you to do this and you bloody do it now. You are all adults. If I come and tell you, I went and told my niece that you are wearing sleeveless, don't wear sleeveless. She said that, uncle, we sent you to England to become a doctor, you'll become a mullah. That was the words he told me. I know these words, but when it comes to learning, we are not able to take our own responsibility. And the other thing, which is the most amazing thing, that when I and our seniors, there was not much internet, there was no Dr. Google, there was nothing. We used to sit for hours in the library. Now, for nephrology trainee, you go to ISN, first of all, you become, as a trainee, you become a free member. You can become a free member of ERA, you can become a free member of ASN. Just, you fill in, get some your supervisor, you just become you get a membership number, you go and you can access all the journals and also their educational material, which is the most important thing. You can access all the webinars, which I did a webinar just 1 month ago on bone disease, etc. We are constantly asked to just go, and those webinars, etc., are done for the developing countries. And they're advertised, but if you need to be a member, membership is free, they will be advertised, and it is done at a time which is appropriate for you. So I did it at 11 in the morning so that it fits your timetable of 7 o'clock in the evening here. Use all those portals. Knowledge is at your fingertip now. And if you want to be competitive here, but more importantly at a national and international level, you need to up the game. So that you become good consultants, and once you become good, sound consultant, you will be able to be respected. You will be respected by others. And because of that respect, you will be able to even change the curricula of your medical schools, which is a bloody... King Edward's, they said it, they celebrated 150th birthday. They told us, isn't it? The curriculum is 150-year-old. They have not bloody changed an iota. And when I went to the dissection hall, I saw Gray's Anatomy. I could not believe nobody does Gray's Anatomy in the West. In that big book, So we need to bring fundamental change in how we do in medicine, how we do self-learning, pride in what you are doing, developing evidence base for your own local practice rather than believing in what I am saying or I write or whatever. And when you're reading a guideline, last thing I would say, this is the last sentence, that when you're like, was it you, Farooq? You showed your conflict of interest. Yes. This is our practice. When we do any talk, I would say that I've got no conflict of interest. By that I mean that I am not in the Hira Mandi of pharmaceutical industry or whatever. Nobody's paying for it. I'm honest man. I've got no affiliation. So if I say about a drug is good, it's my personal. It's not because I'm getting some honorarium from a drug company. Now go into the guidelines. This is the last thing I would say. And I've done that work with one of my PhD students. We went through all the guidelines, not only nephrology, every. And not the current one, the last 3 ones, when it has become mandatory. In the last 15 years, it has become mandatory that if you are writing a guidelines, all the authors of the guideline would put their conflict of interest. This has become mandatory. But that is not in the main document. It's in the appendix. Go and read that. 90% of the guidelines are written by people who are on the payroll of a drug company which is also in the guideline. And that is what we now practice as biblical statements. My trainees, they write to the GP that our guidelines say to do so. This has now become, guidelines has become a business. If you want to do guidelines, then do it yourself. Write it for your own local practice. And that will come from your own effort. And this is what I'm preparing you for the future. Your future is in your hand. It's not determined by me. It's not determined by anything. But if you were to be desired, if you still desire that, yes, I'm happy to be humiliated by Professor Yaqub, and believe me, when Ahad was there, I was more tough on him than anybody else. You can come by ISN, and you can come by ERA. They do fellowships. I'm the educational ambassador. You go onto the website, fill a form, and say, I want to go and work with Professor Yaqub for 6 months. They will pay for your airfare. They will pay for everything. Come and spend 6 months with me. Whatever your area is, we will try to help you out. This is one portal. There's another portal, which is, I think, not being used in nephrology, that one, is the MTI scheme, which is Medical Training Initiative started by Royal College of Physicians. And I asked this question to the Vice Chancellor of King Edward's University yesterday, and I didn't get that straight answer. I think there are some problems with the College of Physicians and Surgeons here. But that is the best, another parallel scheme where after you have qualified, you've done your FCPS, you've done your nephrology training completely. If you want to have 1 or 2 years of exposure in the Western medicine, which is like England is, I would say, is a very good system. You'll learn a lot. You can then come through that scheme to Royal College of Physicians. You don't need to be MRCP. By the way, you can become an associate member of Royal College of Physicians free, completely free, and get access to all the educational material as a trainee. And Royal College of Physicians is a very good training and education portal. You just come via them, you will be matched. If I have a gap in my training program, you will come and become a registrar in my unit. You will get the same pay as another registrar is getting, because ISN and ERA fellowship is quite modest, isn't it? It's quite. But the MTI scheme gives you the same amount of money, and then you come and join. So there are 3 or 4 ways if you want to further your careers. But I can tell you that you don't need it. The amount of clinical material there is here. you don't need us. And maybe we will train you for the something when you come back here, like you were saying that you are international trained, but the facilities are not there. So that could be, I'm preparing a workforce which comes back to this country, and if not, you are not ready for that sort of a, because I will train you with the way we do. And having visited 3 units, I can just say that the one thing which you guys need urgently is to get your diagnostic sorted. This is the one thing. I am horrified that Shaukat Khanum, which is the cancer hospital, interprets your renal biopsy. I cannot believe that a city which is doing so many kidney transplants, there is no disease donation program, and we are building the liver unit for transplant. This is the strategy of this country. But there is no central histology service. There is no central tissue typing technique. What do you do for tissue typing? We outsource it. Have you got any accountability of those institutes who are doing this? That are they doing the right thing or the wrong thing? Do they check how good their reporting is? How good? Your patient didn't believe the biopsy report himself and he sent it to America. This is the trust your patient has got in the services here. I need say no more. So, Professor Mund, I know you are retired, I'm asking too much. You've got to give a think process. If you decide that you are interested in creating a free, or I would say not free, because in Pakistan there is nothing free, not non-profitable tertiary service for renal histology, where all the Lahoris or even whole of Punjab will be free to send a specimen to that service, and they will get a biopsy report which will be as good as an American or English biopsy report. I'm very happy to help you with that, because I've done that for SIUT. And I'll be very happy to help you to create that. But the one condition is that it's got to be non-profitable. And even if you're charging for a private patient, the money should go into a charitable account which will be reinvested into furthering that. And that should become a hub for a registry. So 3 years' time, if you've got facility, you come and tell me that we see so many membranous, we see so many this, we see so many things. And then you will come here and say, can you do your patient randomization? Because you have got so many patients, we don't have it. And in order to do a clinical trial in UK, it's so expensive that they are now going out to China and India. They should come to Pakistan. They will pay you £1,000 per patient to recruit a patient and do a clinical trial. That £1,000 will pay for 3 of your fellows to go and attend a nice meeting. This is how I do. But I am very happy. I've spoken to Ahad, and we need a person who is of, all of you are very distinguished, but you possibly, I would just request you that just think, and if you can't find somebody, and you need to find a place, because there is a lot of philanthropy. We saw at Jinnah. I was impressed. I was blown over by the facilities they have created, how good philanthropy can do. So there are people who are willing to give money for such sort of an initiative. We need to find nice, committed people who would be, so rather than me sitting there and say, I don't believe the renal biopsy which you have taken, in a country which has got atom bomb, and we sitting there, and I felt embarrassed, and none of you said, how dare you talk about our diagnostics like this. I don't want anybody else to. I can say that because we are all Pakistanis. We are the same. I can talk. If you don't criticize each other, we'll never learn. I have said that in this visit, I found the biggest hole in nephrology in this country, and possibly in the whole of Punjab, that you don't have a reliable renal histology service, which you should be able to believe. Same day service, Ahad was there. Biopsy done in the morning, by evening, I would go and see the biopsy report whether it's rejection or not. Possibly you see it from Shaukat Khanam and he doesn't even know what he's talking about. He's never, what vascular rejection, what he would know, an oncologist about vascular rejection. How much BK nephropathy is seen here? Possibly you don't even look for it. You don't have even the serology. All these things can be put in place. So then everything else would fall into place. So at least you will be confident that I made the right diagnosis and then I do A or B or C. You learn from it and then move on. So, sorry I bored you. I was a bit quite aggressive in my approach. But just think that I'm like a fatherly figure. And whatever I said, don't take it to your heart. It is purely for your own, because it hurts me to tell you all. My father used to say that अभी तो बहुत खराब लगता है, बहुत बुरा लगता है जो मैं तेरे को बोलता हूँ. जब तेरे खुद के बच्चे होंगे जब पता चलेगा. How correct he was. Second thing he said, मैं तुमको डांटता हूँ इसलिए कि मुझे तुझसे प्यार है. अगर मैं तुम्हें नहीं डांटूं, नहीं करूँ, इसका मतलब I would like you to make these mistakes again and again. So take it from an old person who feels for your well-being, whatever I said. And even if you do 10% of what I told you, I have done my job. Thank you.
Thank you very much, Mr. Mahmood. It was a real pleasure to have all of you here and listen to such an enlightening talks. And no doubt, you have pointed very valid points that we all know that. But you have made us a little more enthusiastic in terms of going into the right direction. And in the presence of Dr. Junaid over here, he has offered his services also to improve our interventional radiology, intervention nephrology further. And I think diagnostics are on the way of improvement. There was no talk about nephropathology when I came in 2007. When I went to Fatma Memorial Hospital in 2010, so we asked the pathologist to who does the nephron, the renal kidney biopsies, then nobody was aware of that. So we established a renal pathology interest over there, and then it created a further a wave of interest among the other nephrologists to see the biopsies themselves. And we had 2 or 3 conferences where we had the nephrologists and the pathologists all joining together and reviewing all the biopsies. So the change is coming, although it is on a slow pace, but I'm sure our youngsters, as you have rightly addressed to them, and they are our bright future and they are going to do something better for us, inshallah. In terms of the curriculum, there are certain changes already happening, and the PMDC regulation and other things, the curricula has been changed like 2 or 3 years ago, and there is still a further committees that are working on changing the curricula to the next level, and that is more of an integrated. But I'm sure there will be always lapses and weaknesses that we are going to, inshallah, overcome in the future. In the same way, in terms of our data, we have said it again and again and again. And we started this Pakistan Journal of Kidney Disease by the Pakistan Society of Nephrology. Professor Zalman is the chief editor. And we have just requested all our nephrologists just to chip in their data. What they have, what kind of dialysis patients they have, what kind of patients they are seeing in the clinic. And this is going to be a wealth of data that is going to lead to our understanding that what is happening in the nephrology community in our patients. And from there we can lead on and go further. And at the same note, I would like to have your some help in terms of biostatistics, in terms of teaching, maybe some webinars, maybe some some other collaboration where we can ask you or you can guide us somewhere, where you can have some good suggestion in terms of how to set up the studies, if there are any studies that you can look on, that it is feasible to do, or what are the weaknesses in there. So with that note, I would like to thank you and Dr. Omar, Dr. Tariq, and Dr. Khalil coming all the way from Ahmedabad, and Dr. Arif Asif for being here and sharing all this knowledge with us, and with the same enthusiasm and with the will to help us out. I expect that you will be here in October, inshallah. For the lunch now.